Good morning, everybody, and welcome back to the Journal Club. It's great to see all of you connected so early this morning. So it's a great welcome to Federica, who will be joining us for this Journal Club presentation of a very important article, which is the systematic review and meta-analysis looking at mortality after bleeding in comparison to myocardial infarction. And it's a great honor and a pleasure for me to invite Professor Esposito from the University of Naples. Thank you, Professor, for joining us, and look forward to a great discussion together, everybody. So, Federica, you can take the stage, please.
Okay. Can you see my screen?
Perfect.
Okay, good morning, everybody. I cannot say a Sunday morning from Naples because it's raining like everywhere. And thank you very much to Professor Esposito and to GSA Journal Club and to MCH for giving me the possibility to present this paper today. So, talking about bleeding risk, as you can see in this table, many studies, many papers have been published in recent years, and these are just a bit of studies presented from 2012 to 2018 about this important topic. And in this table, you can see also many scores published, like REACH, DACHASA, DAPT score that we know perfectly, Paris, Precise DAPT, and BLIMAX. So bleeding risk is very complex to talk about. As you can see in this image, there are many factors which influence bleeding risk. Aging, comorbidities like renal, liver disease, active cancer, laboratory data, anemia, low platelet count, central nervous system problem like stroke, intracranial hemorrhage, bleeding history like bleeding diathesis or prior bleeding or transfusion, and iatrogenic as OACs and NSAIDs or steroids, and planned surgery on that. On the right, you can see a table talking about classification of bleeding risk, which has been published in Circulation in 2019, dividing major and minor criteria for bleeding risk. And let's move to our paper. This is a systematic review and meta-analysis recently published on error intervention, and I very thank Professor Raffaele Piccolo, which have borrowed me this paper for this morning, and Professor Esposito, of course. This review and meta-analysis talk about mortality after bleeding versus mortality after myocardial infarction in coronary artery disease. Let's move to the methods. Patients with CAD, irrespective of their management, so medical therapy, PCI, or CABG has been pulled together, and the association of both bleeding events with mortality and myocardial infarction with mortality. Risk estimates were adjusted at least for age, and an electronic search from database inception to January 2021 has been performed. To determine the relative effect of bleeding on mortality versus MI, the hazard ratio has been divided by the hazard ratio for MI, developing a ratio of hazard ratio. So a value measured than 1 indicates a stronger association of bleeding with mortality in comparison to the association of MI. A value minor than 1 indicates a stronger association of MI in comparison to bleeding. So hazard ratio and the ratio have been pulled together with an inverse variance weighting random effect model, and study protocol registration has been made in Prospero. These are the main results. Talking about overall risk of mortality after bleeding versus myocardial infarction, 16 studies have been selected with 141,000 patients published between 2008 and 2020, with a median follow-up of 22 months, with 91% of patients that received PCI and 63 presented with acute coronary syndrome. As you can see in the plot, in every study there is a higher risk of mortality with bleeding, of course, on the top. In the center you can see that there is a higher risk of mortality with MI in all the study. And in the bottom you can see that in 2 papers there were a strong positive association with bleeding than with MI. Only in 1 paper a significant stronger positive association with MI, while pulling together the data in the overall, there was not a statistically significant association of a stronger positive with bleeding, but there was a tendency on the right. Risk of mortality after early events. This is very important. Early events were considered within 30 days. 7 studies with 51,000 patients has been considered, with a median risk of bleeding of 3.5% and median risk of MI of 5.2%. And these are the data. Also here we can see a higher risk of mortality with bleeding in all the studies and in the overall. A higher risk of mortality with MI in quite all the study and also in the overall. While pulling together the data, there is a stronger positive association with bleeding than with MI in the first 30 days. These are the late events, so after 30 days. 8 studies with 94,000 patients with a median risk of bleeding of 3.1 and median risk of MI of 2.9. These are the data. Also here we can see a higher risk of mortality in all the studies and in overall. A higher risk of mortality with MI in all the studies and in overall. While pulling together the data, there is no statistical significance of stronger positive association, nor with bleeding, neither with MI. And now let's move to minor bleeding. Bark type 3 bleeding or more was used as reference for major bleeding. So these are the late minor bleeding with a high risk of mortality with bleeding in 4 studies and in the overall, a higher risk of mortality in all the 4 studies and in the overall. While pulling together the data, in this case, there is a stronger positive association with MI than with bleeding. And these are the conclusive slide. As you can see on the right, in the overall event, there is a balanced risk between bleeding events and myocardial infarction as related to mortality. While in the early events, and this is very, very important, there is a stronger positive association with bleeding than with myocardial infarction related to mortality. In the late events, on the right, there is also a balanced risk between bleeding events and myocardial infarction as related to mortality. I cannot carry conclusion, but only questions to Professor Esposito. This meta-analysis underlines the role of bleeding in CAD patients. Do you think this could change our approach as interventional cardiologists, especially in the early phase, and in what manner? In your opinion, what is the role of periprocedural pharmacological therapy in bleeding outcomes? And how is Jesus Society aiming to emphasize the importance of bleeding risk and its outcomes? Thank you.
Great. Thank you, Federica, for the nice summary of this important topic. So, Professor Esposito, can I please invite you for your comments?
Yes, thank you. Thank you very much. Thank you, Federica, for the brilliant presentation. Obviously, I'm a little bit biased because I was one of the authors of this paper, but I think this paper very nicely pointed out one of the concepts that mostly how we in the CAT lab, we are not really clear the risk of bleeding and the risk of thrombotic risk in our patient. And what is very clear is that the early phase of PCI, it's the one most in which the bleeding risk is one of the main cause of the main events. So I think it's very important that we have the real perception of which therapy the patient in the periprocedural phase of the myocardial infarction need to be done. I think one of the most events are driven from the triple therapy. I think the triple therapy, especially in the patient with the atrial fibrillation, it's one of the main reasons why in the early phase the patient bleeds, and so the events are driven mostly also from this one. And I think the literature and all the studies that we are doing in the last couple of years, so more than 2 years, are to reduce the bleeding risk and reduce the triple. So the guidelines are changing regarding that, and we do mostly triple therapies only in most of the patient with not the thrombotic risk, not much very high, only in the hospital phase, while we are discharging the patient with the dual therapy. And this is one of the main, I think, to address this problem. It's one of the solutions that I think it's very, very important. And regarding what the GISA can do, I think we have the perception of thrombotic risk that is changed during the past 10 years, because in the early phase, in the few years ago, we were a little bit, we are very concerned about thrombotic risk. But now with the new generation stent, I think in the cath lab we can make very, very safe the stent implantation and the stent optimization with the imaging. I think it's one of the main target that we need to have to reduce the bleeding risk. Because if we really implant the stent in the good manner and not optimizing the stent implantation in the imaging, we can reduce the thrombotic risk, and we can reduce also the necessity to have a patient with a triple. And I think this is one of the things that we can do in the cath lab. And for GISA is this problem is one of the main main target of GISA in the past 10 years. We started with the Matrix project that was sponsored by GISA, because bleeding is very, very a concern with GISA. Besides the technical approach in PCI, the pharmacological therapy it's very important for us. And more recently with the Dubious, in which we studied published on GACC, we studied the pre-treatment in non-ST-up elevation patient with ICS, and we would demonstrate that it's not the pre-treatment of a patient in this setting of patient. That does not lead to in reducing the events, and so this is important. That's the bleeding risk and the pharmacological phase in patient in the cath lab. It's very important for us, and we have done several studies, and we are doing more and more studies, because it's something that, as Federica showed in this meta-analysis, is something that really matter in the outcome of our patient. So we can do a perfect and brilliant PCI, but if the patient bleeds, then all of that we did then will affect the outcome of our patient. So it's something that we need to really take in account.
Okay, thank you very much. So I'd like to invite the audience, if there are any questions, if anybody would like to come forward and pose the questions either regarding the paper or this topic.
Professor, this is Julia. In your experience in your cath lab, in a practical way, how do you select the perfect DAPT or triple therapy duration? You speak with the clinician, you write it on after doing the exams, or how can you manage this problem?
Yeah, this is a very important question, Julia, because the problem is that in the routine patient, I mean, not in acute coronary syndrome patient, it's very easy, because you can ask to the patient, you can ask to the family people of the patient, and you can do the analysis in a very detailed mode. The problem is in the acute coronary syndrome patient, older patient that comes also with, in a clinical not really good situation, like cardiogenic shock, or a patient with not, in which it's not very easy to address the bleeding risk in this patient. So in this patient, we try to use drugs with cangalor that can help us, for instance, to have all of us know. We all know the pharmacokinetic of cangalor, that it's very useful for those patients, because later on you can then have the data in which patient bleeds previously or had some bleeding accident, and as we have seen in the beginning of the discussion, as Federica showed, this is one of the previous bleeding is one of the predictor in bleeding. So, not all the time you can address the bleeding risk in the patient very clearly, and you can reduce in the cath lab using drugs that are not. You can manage therapy in this way, and for other people, we have we calculate when we can the bleeding risk of the patient, and our concern is on older patient, as you have seen, is on a paper with the CKD, which are another classic set of patients that bleeds very often too. And also patients that are on atrial fibrillation, that are NOAC or AD anticoagulation. So it's very hard, especially in the acute coronary syndromes.
So sorry, just to conclude, do you suggest to calculate like the HBR arc criteria or the precise DAPT score in the cath lab to guide the choice of the APT and triple therapy duration?
Yes, actually, we are conducting a study in our institution. Actually, in all the region, Campania region, this is the Parthenope, in which we are doing an analysis of prospecting the DAPT score, in which we are trying to address this question, especially in patient with the HBR. And this is something that we are, very pursuing. That it's very important, because all the scores are, most of them are retrospective, data. But I think also have a prospective data on these scores is very important. And what are trying to do? We almost finished the study. We expected to enroll 2,000 more than 2,000 patients. We only have a couple hundred patients, to do. And I think in a few months we will finish the study. This is something that we are pursuing, because, as I said, and also it's very important.
I have a question generally, because as young fellows, there's a lot of literature on bleeding, and following on from Julia's question, there's a lot of criterias also for assessing bleeding risk. But when you're faced with acute coronary syndrome, of course, the antiplatelets are not only addressing, let's say there's a bigger role for them to play than in simple coronary disease stenting. So if I understood correctly from the meta-analysis presented, majority of the big bleeding risk was in early events after MI. So the end goal that we're trying to achieve with all of this, or is what? Is it to try to shorten, forget the triple therapy, but just dual antiplatelet therapy? Is the goal to try to shorten dual antiplatelet therapy duration or intensity? Because in acute MI, it's very difficult. Especially, I suppose, at our stage where we're trying to get experience with different drugs and patients. So what would your advice be to us young fellows, that, because generally from what I've seen, clinical practices, MI equals 12 months, stop. But should we change our thinking?
Yeah, this is important, but as we have seen, the bleeding is especially in the first period, 30 days. And I don't think that we can shorten less than 30 days the APT. So I think this is something that we cannot really change in our clinical practice, because we can reduce the late bleeding that still exists, because the meta-analysis does not show that clinical late bleeding are not important. It's not something that is different from thrombotic risk, but either thrombotic and bleeding in the late period are very important too. So I think we still need to have concern about the bleeding risk also in the late phase. Regarding the early phase, what is important is that we need to do a potent dual antiplatelet therapy with actually also the ISA-REACT study 5 that we have seen now shows also that not only ticagrelor, but we can safely do also patient with prasugrel. But what is important is the thrombotic risk. I think what we need really to do is to address the risk of patient, either thrombotic and also the bleeding risk. That is something that in the clinical practice we don't do very often, because the patient come and we do, we load the patient without do any calculation of the bleeding or thrombotic or either something that is not been in the clinical practice. These scores that are very important in, at least in the retrospective manner, it's something that have been not implemented in the clinical practice. So what I think and what I recommend is that especially in the older patient, especially in the patient with either thrombotic or higher bleeding risk, we need really to make a calculation and to make really to address in a very, very detailed when we can do that. And when we cannot do it, use drugs that can you can really manage. Let's see, if become a very old patient with cachectic, with in a status very hard to address, and I think Kangor can be a solution. But we need really to address the risk of thrombosis and bleeding in the acute coronary syndrome patient. It's something that is not been still implemented in the real clinical practice.
Okay, thank you. We have a nice question in the chat, which is actually, I think, a clinical scenario that's encountered not so infrequently. So, Federica, I'd like to ask you, in your institution, if you have PCI and you start, dual antiplatelet therapy, and the patient has an acute bleed, or let's say a gastric bleed or GI bleed, in your institution, generally, what is your pathway or what is your protocol for managing these patients? I ask you because all of us work in different places. It would be interesting to get your perspective. And then, Professor, afterwards, how would you advise that we manage this situation? Because it's a very difficult scenario. And often I think the challenge is that the question comes back to us as cardiologists, and we are the ones who are predominantly have to answer the question and decide what to do.
Okay, I answer first. Of course, it depends on the hospital, because I had the possibility to work in a big hospital where everything is available. So if the patient has a gastrointestinal bleeding, I have at the third floor just under me the gastro team that can manage the bleeding, and then the patient come back to me. And this is very important, because if you work in a little hospital where you cannot have all the management of every possibility, I know maybe you have the general surgeon, but you cannot have the neurointerventional radiology, the vascular surgeon, the vascular radiology, and so I think it depends a lot on the management and the organization of the hospital. When a patient have a bleeding in my institution, we all, of course, tend to solve the acute phase, stopping that, and then together with the specialist, we choose the management, and of course, we can use like little molecules, tirofiban or something like this, if we need in the very acute phase, and then we tend to reintroduce that as soon as possible, but always together with the other specialists. And I am very grateful and very lucky to have the possibility to do this, because in the previous hospital, I did not have all this possibility. And then, you know, if you lose the patient that has been transferred, you cannot know what is the choose.
Okay, nice. Yeah. And Prof?
Well, I think it's a dramatic events when the patient bleeds, and I think what you can do is stop that and stop bleeds, as you can in the way that you know, depending on the clinical scenario. And when you have the problem, real problem is that when you start again the duct, if you and what you find, because if you find something that you can you know, address, let's see, something in the that in the colon that you can, you know, remove, or something that cause the bleeds, it's in some way easy, because you remove the cause of bleeding, and you can restart very easily. In other situation, this is very, very difficult to do. And since the bleeds is in the early phase, what you can do is start something that drugs that you can easily you know, manage from a pharmacokinetic point of view, and short the duct. So if your plan was like 3 months or 6 months, in this patient, we obviously everything is changed, and what we do in this patient, we have a very, very ultra short duct, even if we restart duct after bleeding, and we do 2 weeks of duct in those patients, and especially in this patient, we need to use a stents, coronary stents that are we have a lot of it now. So in patient that we don't know the bleeding risk, we usually try to use stents in which you can do the ultra short duct, let's see, Discussant or other several other stents that we have in the cath lab. And from the other question was.
No, no, it was essentially like you answered, you know, when we're faced with this scenario, what to do. I mean, we have to stop, but the question really is what to do afterwards. So, no, thank you. We have a nice question on the chat. Somebody's asking about the Pegasus trial and its exclusion from this meta-analysis.
Yeah, because the Pegasus, the endpoint of the Pegasus is after 1 year. So you start the Pegasus, enroll the patient after 1 year of acute coronary syndromes. So it's not a study that address the endpoints are late, more late than the target of the studies. That's the problem, the reason why we have to do that.
Okay, thank you. So I think we're perfectly in time. So I would just like to say thank you very much, Federica, first of all, for joining us. It was great to have you on board and for presenting this paper. Thank you. And Professor, thank you for stimulating the discussion, sharing your insights and expertise. We really appreciate it. So thank you. I certainly hope that you will join us again. It would be a real pleasure for us. For those of you still connected, I'm delighted to announce that next week we will be broadcasting live from the EAPCI Fellows course. So do join us. We have a very exciting session in store. And Ollie De Backer from Lars Sondergaard Group will be joining us as our expert to discuss the hot topic of commissural alignment. So it's something that's been discussed quite a lot, most recently, especially at PCI London Valve. So we have the opportunity as young fellows and involved in these procedures, learning them, to hear directly from the experts who are developing these techniques. So do join us next week. Please note the time will be different as it's at the EAPCI Fellows course. So it'll be at 1 p.m. But we very much look forward to joining you and connecting with, I don't know how many hundreds of fellows around the world together. So have a good Friday and have a great weekend, everybody.
Thank you, everybody.